Good afternoon. It's my great pleasure to introduce a guest speaker this afternoon. And actually, okay. And I will continue to introduce the guest speaker. Yousuf Zafar is an associate professor of medicine at Duke, and one of the reasons I'm particularly pleased to have him joining us here is that he's really a national leader in this field of addressing and understanding how cost of care is affecting our patients with cancer as they journey through the cancer trajectory. We often hear these data about healthcare costs in aggregate, how the US is spending 17% of our GDP on healthcare costs, and cancer costs add up to billions of dollars per year. But what Yousuf has done is really translate these aggregate and somewhat obscure big numbers into actually the impact and how they affect patients. He's a speaker nationally and internationally on this topic, and we're really excited to have him join us here. So, Yousuf, thank you.
Thank you very much. Is this on? Yeah. Okay. It's really an honor to be here. Thank you all for having me. So, like Harry said, I'm very interested in the cost of cancer care. And a lot of that cost has to do with, of course, the pharmaceutical industry. So before I should start, I need to show my disclosures and potential conflicts of interest. As you can see, my wife is employed by Novartis. So even though I spend a lot of time talking about cost of care, I am quite literally married to the pharmaceutical industry. Let's wrap our minds around that for a minute. Makes for interesting discussions in the conflict of interest office at Duke. All right, so before we start, I need a little bit of audience participation. We're going to watch this brief video, and you're going to need to follow the directions very closely, okay? The directions are going to be count how many times the players wearing white pass the ball, all right? And I ask you, raise your hand afterwards to count how many times. So again, focus on players in white. All right. 15. All right. It doesn't really matter. Did anybody see the gorilla? Yeah. Anybody not see a gorilla? Oh, you guys follow instructions very well. Let me show you the gorilla for those of you who didn't see it. And really one is just you. There's a gorilla. So the reason you didn't see the gorilla is because I asked you to focus on the players wearing white. And so you phased out all of the black shirts, right? And this was an experiment from 1999. And actually, when this was first done, about 50% of the participants did not see the gorilla. So what does this have to do with value in cancer care? It has everything to do with value, because value is actually all about perspective. Value is about your perspective in terms of what's important to you and what you've been told to look for, and what you perceive as important for those around you. And in fact, you could argue that value in healthcare depends on who is looking, where they look, and what they expect to see. So you look in a textbook and you look at value in the dictionary, you're going to see this equation, right? Value is quality over cost. But whose quality and whose cost? And I would say there are at least two perspectives to value, all right? There's at least a perspective of the society and the patient, but this is way oversimplified of a model. Because when you think about society, right, within society you can think about the government, you can think about payers, manufacturers, and health systems. And then from the patient side, I would say patients, and I like to lump myself in with patients as well and say patients and providers, right? So let's for a second look at the oversimplified view and think about value from the perspectives of society versus patient. And when we think about value in society, it's sort of what Carrie mentioned, right? We think of these numbers. We think of hundreds of billions of dollars in terms of cost of cancer care. And that's what the numbers are, right? From 2020, cancer care overall is going to approach $200 billion. Those are huge numbers, and they're very hard to comprehend at the level of the patient. But why are those numbers so high? Well, as I said, I think a lot of it, in cancer care at least, has to do with the drugs that we prescribe. So we have seen a tremendous rise in the cost of drugs over the past few decades. So each one of these dots you're going to see here represents a cost of a month of chemotherapy. So from the 70s to the 1990s, a month of chemotherapy cost a few hundred to maybe a couple of $1,000s. After the 1990s, we see this huge jump in the cost, where now the average price of chemotherapy is in the range of $10,000, $20,000, or $30,000 a month, and those are a lot of the drugs I prescribe every day I'm in clinic. And so why is that? Well, a lot of it has to do with the type of drugs that are entering the market. So in 2003, biologic agents comprised about 10% of the oncology market. 10 years later, they comprise about half the market, and that trend continues, particularly if you count some of the immunologic agents, much of that work which is being done here on those drugs. And those drugs aren't cheap either. But what's interesting is not so much the price of those drugs as they enter the market, but what happens to those drugs a few years after they've been on the market. So I'm going to show you the prices of a few drugs. These are all oral biologic agents, all right? From 2007 to 2014, look at this scale, all right? This is per pill. So the price of erlotinib increased by 91% in that period. Dasatinib increased by 130%, and the drug we all like to pick on, imatinib, increased by 158%. So there are a lot of reasons as to why this is happening, and I think it would take a whole hour just to talk about that. But there's some conjectures as to why. So some of it is because the pharmaceutical companies have other drugs that are coming off patent, and in order to cover those prices of the off-patent drugs, they increase the price of the high-demand drugs that are still on patent. The question I have when looking at these numbers is, so what are we getting out of it? What's the benefit? And that's the benefit part of the value and cost equation. So here's one way to look at it. This is the price of developing one drug per decade. Now keep in mind, these numbers are contested. Not everybody agrees with them, but they at least give you an order of magnitude, right? So from 320 million in 1980 all the way up to 2.6 billion as of last year. So what's the benefit that we're getting out of this huge investment in drug development? Well, let's overlay 5-year survival, all cancers from seed, all right? And despite a doubling in the production costs per drug, we're seeing a plateau in improvement in overall survival. Now, I grant you, this is not the fairest comparison for many reasons, right? But let me show you another way to look at the value that we're getting out of the cost that we're investing into these drugs. So this is a study that was published in JAMA Oncology earlier this year. And the investigators looked at 52 drugs with oncology indications to determine how much their cost was compared to their increase in benefit. So they looked at drugs that had a phase 3 comparator arm in their approval trial, okay? On the y-axis, you've got cost of drug, and on the x-axis, you've got percent improvement compared to each drug's comparator, right? Makes sense. So what the investigators found was that there was little or no correlation between the cost of the new drugs entering the market and their improvement in benefit. So for example, if you look at this drug, which is the most expensive drug on this list, it had less than a 20% improvement in overall survival compared to the standard of care. So based on these results, the investigators concluded that current pricing models are not rational, but simply reflect what the market will bear. So what is acceptable, right? So if drug prices keep going up year after year, what do we think of as acceptable? Well, in the United States, an acceptable amount to pay is somewhere between $50,000 and $200,000 per year of life gained after adjusting for perfect health. So you guys have heard quality adjusted life years, right? So after adjusting for quality, we say that paying somewhere between $50,000 to $200,000 is reasonable. In Europe, those numbers are lower, all right? So let's look at one of the drugs that actually I don't use very often, that was recently approved for colorectal cancer. And there was a cost-effectiveness analysis that was done again earlier this year, which looked at the cost-effectiveness of this oral drug in colorectal cancer. And for a year of life in perfect health, this drug would cost nearly $1 million. All right. So again, the manufacturers of this drug have talked to me about this study and dispute it heavily, not surprisingly. First of all, because nobody takes this drug for a year. And they sort of argue with the methods, but it's fairly standard cost-effectiveness work. And if you believe in cost-effectiveness research, these are the type of numbers that you get. But the problem with these type of cost-effectiveness studies is that they don't do anything, right? These studies are published years after sometimes the drug's already approved, and it already has a price tag in the US, right? So these same investigators decided to do something different, and they did a cost-effectiveness analysis on a drug that was yet to be approved. In fact, it just got approved last week. Right, just got approved last week. And I looked it up, and I couldn't figure out what the actual pricing is for the drug. But based on their cost-effectiveness analysis of this EGFR inhibitor for metastatic squamous cell lung cancer, which had a, correct me if I'm wrong, but I think 1.6-month improvement in overall survival compared to standard of care, they estimated that a one-cycle cost of this drug should be somewhere between $500 to $1,300 per cycle. You're laughing because it's funny. There's no way, and again, I mean, this is speculation on my part, there's no way that when this drug eventually gets its price tag, it's going to cost this much. And in fact, if you look at the trends and some of the numbers I've already showed you, it's probably going to be 10 times as much. So, that's what's happening from a societal perspective. That's what's happening when we talk about cost of cancer care and value from the societal perspective. But what about from the patient perspective? And this is where a lot of my work comes into play, because I really focus on the interface between the bill that the patient receives and the quality of their well-being, of their life, and of the care that they receive. So when you ask patients what do they value, right? First of all, they say, I have no idea what that means. Because, I mean, just think about it. You know, if you were facing a life-threatening illness and somebody asked you, well, what do you value? It's going to be a very difficult question to answer. But I would say most people would value a cure or a quantity of life or quality of life. I think particularly, you're seeing a patient for the first time, this is not going to come up very much, right? I guarantee you, though, it's there. Even if the patients aren't verbalizing it, cost is still a factor. And it's a factor because patients are paying a huge amount out of pocket despite having insurance. So Amy Davidoff did some wonderful work in estimating how much Medicare patients are paying out of pocket. And half of all Medicare patients are paying at least 10% out of pocket on their cancer care. So by definition, every other patient that you see in clinic with Medicare is underinsured, because that 10% threshold is typically what we use to describe underinsurance or poor quality insurance. But the numbers get worse, right, Amy? So 28% of Medicare beneficiaries spend more than a fifth of their income out of pocket. So I think a lot of people, and correct me if I'm wrong, you've probably heard more, but a lot of people discount these numbers by saying, well, that's patients who have Medicare who don't have supplemental insurance. By definition, they're going to have a 20% out of pocket. Well, that should only be 10% of Medicare beneficiaries, because only about 10% of Medicare beneficiaries don't have supplemental insurance. So something else is going on here. And something else is going on with cancer care, whereby patients are facing a tremendous out-of-pocket burden despite having insurance. So a lot of that has to do with the cost of care, as I've described already. But a lot of it also has to do with cost sharing. And insurance is becoming more expensive as payers are shifting the cost over to patients. So again, the first example of cost sharing is the price of insurance itself and premiums. So this is data from 1999 to 2013 with percent change on the y-axis. So you've got inflation as a baseline Worker earnings have kept up with inflation. Premiums have gone up by 182%, right? And that's fine because you say your employer is covering that. Well, worker contributions to premiums have gone up by nearly 200%. So we're paying more for insurance even before we're hit with a catastrophic illness. On top of that, deductibles have gone up, and in fact, in the past few years, deductibles have nearly doubled. And a lot of that has to do with the high deductible plans, the plethora of high deductible plans that we're seeing entering the market under the Affordable Care Act. So another form of cost sharing that I think is particularly important to our patients is the tiered formulary. And so for those of you who don't know, a tiered formulary is basically where certain drugs will incur particular copays based on where they fall in the formulary. So generic drugs will usually have, be on tier 1, where they have little or no copay, while the expensive oral chemotherapies that we prescribe and many of the expensive supportive care medications we prescribe, like MS-Contin, fall into the higher tiers. And we've seen this surge in multi-tiered formularies. So you could be assured that when you send your patient home with a prescription for an oral oncolytic agent, just having insurance is not sufficient to protect them from financial toxicity. And in fact, we're seeing more evidence of what's happening when patients are feeling this financial burden. And what's happening is, in the most extreme cases, they're going bankrupt. So this is really wonderful data from Scott Ramsey in Seattle, where they'd done something that hadn't been done before. So they took SEER data, and they merged that with state court data and bankruptcy data. And so they actually, they have a judge as a collaborator. They merged that data, and what they were able to find was that they compared all bankruptcies and cancer patients compared to controls, and they found that patients with cancer had a 2.65 higher chance of declaring bankruptcy compared to those without. So just having a cancer diagnosis more than double the risk of declaring bankruptcy. So that was a really interesting study. But they took it a step further earlier this year. And they presented sort of the next step study at ASCO this year. And as far as I'm concerned, I think this was the most interesting health services, healthcare delivery abstract to come out of ASCO this year. And that's not just because I was the discussant. I grant you that. But they took their population of cancer bankruptcy data, they narrowed it down just to patients with cancer, and they looked at mortality risk. So in a sample of over 7,000 patients, they found that cancer patients who declared bankruptcy were at 79% higher risk of mortality. So now, we're not just saying that financial toxicity sucks. Paying a lot sucks. Having a large bill is a bad thing. Now we're saying, in the most extreme cases, those patients who are experiencing financial toxicity are likely to do worse. So why is that? Right? And again, this is where a lot of the work I've done in the past is focused. Why is there this link between extreme financial distress and greater risk of mortality? So I think this is a fascinating question. I think there's at least 3 reasons why. And the first is, the first sort of mediator between this relationship is well-being. We know that financial distress impacts patient well-being. So the first study that I did on this topic a few years ago that introduced the term financial toxicity into the literature asked patients, so this was a national sample, relatively small, it was only 300 patients, but a national sample of insured patients. So everybody had cancer, everybody was getting treatment, and everybody was insured. And asked them, what are you doing to deal with your costs, with your out-of-pocket costs? So the vast majority had said they had given up things like vacation. About half had cut out groceries and spending on groceries and clothing. And about half had depleted savings. So the median age on this study was 64. So actually, many of these people were spending their retirement nest egg in order to pay for cancer care despite having insurance. So clearly, financial toxicity impacts patients' well-being. And that's possibly a mediator between financial toxicity and worse outcomes, like mortality. What's interesting, though, is what patients are willing to do, right? Because now I think patients realize that they're going to get hit with a bill despite having insurance. There's a second study we did. We asked patients, what would you be willing to give up for your cancer care? Half would be willing to go bankrupt. 39% sell their home, and 73% spend less on food and clothing. What was the discussion we were having this morning about our healthcare system in the United States and how a research career could be built on the fact that we have a broken healthcare system? This is incredibly sad. This is incredibly sad to see, again, insured patients say they'd be willing to go to those extremes just to get treatment for their cancer. So that's well-being. What about quality of life? So this is another important question. We all understand that quality of life is related, has been associated with worse outcomes overall in patients with cancer. And there is now evidence that as financial distress goes up, quality of life goes down. So this is a study we did in 1,000 patients, again, a national sample of patients with lung and colorectal cancer, where we found that high financial burden was associated with worse quality of life in patients with cancer and survivors. So patients who are no longer getting treated still had financial burden related to their care and had worsened quality of life as a result. This wasn't the only study to do so. In fact, the other study came out of Yale. Anis Chugpar's group also looked at quality of life in relation to financial burden and found the same thing, that patients with higher financial burden were 4 times less likely to report better quality of life. So, well-being, quality of life, both potential mediators on that pathway between extreme financial distress and mortality. But I think the one that is most interesting and most important is quality of care itself. And this is where there's been a lot of work describing the relationship between financial burden and lack of adherence to cancer care. One of the studies that I found most interesting was done by colleagues at UNC down the street from me, where they did a study looking at patients who had just been prescribed imatinib within 6 months. And they looked at their copay for imatinib. And they found that patients who had a higher copay for imatinib were 70% more likely to be non-adherent to that drug within 6 months. What's interesting about this study is their threshold for a high copay. And it was $53. So not thousands of dollars a month or hundreds of dollars a month, but a change in a patient's budget of $50 a month could potentially induce them to be non-adherent to a life-prolonging, if not life-saving treatment. We did a study where we asked patients the same thing. We asked them whether they were non-adherent, so self-report of non-adherence. Again, cancer patients with insurance, 45% reported non-adherence as defined as not taking their prescriptions as prescribed, not filling all of their prescriptions, or taking somebody else's meds. And again, I'd say most of the time, speaking for myself, I'm not hearing patients telling me this. Right? So when we're talking about this link between extreme financial distress and greater risk of mortality, these are at least the mediators that I think are involved, but there's probably more. There are probably other factors that we have not yet studied or need greater study. But in short, what we have now is a growing list of evidence-based financial toxicities, where each one of these is there's a study backing up each one of these and how greater cost results in these outcomes. Because we have this now growing body of evidence, I would say that the time is now to intervene. So, how do you decrease the cost of care to patients? Well, that is a tremendously overwhelming question for me. But when I think about it, I try to break that down into 3 levels of interventions. So you have interventions at the policy level, interventions at the provider level, that's us, and then interventions at the level of the patient. So let's go through these 3 levels. So when we're talking about policy level interventions, I think we can break that down even further. And we can talk about pharmaceutical industry, the government, insurers, and health systems. And there are interventions that we can institute at all of these levels that could decrease costs for patients. So let's start with manufacturers. It is not rocket science to say that one way to decrease costs is to lower the cost of drugs. Seems fairly obvious. However, if you look at the data, the trends do not predict any lowering of the price of drugs, or even stability for that matter, in the coming years as we continually see them rise. But I think that would be a first intervention. And I'll tell you, it's happened based on physicians as a group being vocal. I think one of the best examples of that was the drug aflibercept, which is approved for colorectal cancer. And Sanofi, for reasons that are not completely clear, tagged the price at double of what Avastin, its sort of comparator drug, was at the time. And that was because of a dosing issue. For whatever reason, they did that, and investigators, clinicians around the country, and particularly at Memorial Sloan Kettering, were very vocal in saying that they were not going to add the drug to the formulary. We did the same. We did not write an editorial in the New York Times. But that editorial, as I'm sure many of you know, dropped the price of the drug and really changed the face of how drugs are priced. However, I was on a panel a couple weeks ago with Peter Bach, one of the authors of that opinion piece, and he said, ain't no pharmaceutical company ever going to change the price of a drug because of an opinion piece again. That's for sure. But at the same time, you think about Turing Pharmaceuticals, right? So this is a company that bought an old antiparasitic drug that was generic and jacked the price up by 5,000%, thinking that they could get away with that. Because of the loud, vocal outcry on the part of infectious disease docs, every week you see that the price of that drug continues to fall back down. Now, whether it's still in a reasonable range, I'm not sure, but at least we have an effect there where we can impact drug prices. Next on the list is the government. And I think there's a lot that can be done at the level of the government in terms of reducing prices. And the first is correcting a mistake that was made a few years ago. So in 2003, when President Bush signed the Medicare Modernization Act, this was probably the largest overhaul of Medicare since it was developed. And Part D was introduced as a part of the Medicare Modernization Act. But there were 2 lines in this 416-page document, and I checked, it's 416 pages. There are 2 lines in this document, in this bill, that have completely changed the way we price drugs today. In order to promote competition, the Secretary of Health and Human Services may not interfere with negotiations between drug manufacturers and pharmacies and PDP sponsors, and may not require a particular formulary or institute a price structure for the reimbursement of covered Part D drugs. So basically, this allowed the pharmaceutical industry in the US to price drugs at whatever they wanted because we were no longer allowed to negotiate with them. I haven't seen the study yet, but there was a blurb in today's Ask Us communication where there was a study that showed drug prices in, I think it's Norway and the UK, are 93% lower compared to the US. Well, the one thing they can do there that we can't is negotiate. So after the Medicare Modernization Act, the next big overhaul of healthcare delivery and coverage that we've seen, of course, has been the Affordable Care Act. And I think the Affordable Care Act has done a tremendous amount to get people insured. Depending on where you look, anywhere from, 15 to 17 million people now have insurance who did not have insurance prior to the ACA. But one thing I've said previously is I think I would rename the Affordable Care Act to the Accessible Care Act, because I know it increases access. I don't know it actually makes care more affordable. And here's an example. So this is something I did just a couple days ago where I created a fake patient living in Durham County and tried to see how many plans this patient would have access to. So this patient has access to 26 plans with premiums ranging from less than $400 all the way to around $1,500 in bronze, silver, platinum tiers. And I'll tell you, this is incredibly confusing for a patient to navigate. So we just did a study where we looked at 6 counties in Durham. We did the same sort of secret shopper analysis of a patient with CML in their 50s, I think. And we found that patient had access to over 300 plans. And then we varied the access by the patient's income, by federal poverty level. And what we found was completely contrary to what everybody says, right? Everybody says, go for the silver plan, right? The silver plan is going to get you the best coverage. Well, what we found is that poorer patients actually had better coverage with the silver plan, which most think they can't afford when facing a catastrophic illness, while richer patients, up to 300% of the federal poverty level, actually should go with a bronze plan. So we figured that out after 3 of us sat in a room and looked at the data for days, right? How are patients expected to figure that out in an enrollment period when they know they need to sign up for care right away? So that brings us to payers, right? Payers are very important in this equation when it comes to reducing cost of care. And what we see now is sort of a shotgun approach in terms of coverage. You're either covered or you're not. What I would advocate for is more of a targeted approach with value-based insurance, as an example. So value-based insurance is a concept that has been around for ages, but hasn't really picked up steam in the United States. And the way this works is that something that is of high value should be covered fully, and something that is of low value shouldn't be covered at all. So here are a couple examples, right? So if you have just been diagnosed with CML and you're going to start imatinib, you should have 0 copay for that drug, which is your most effective starting option, right? Now, if you are an asymptomatic 30-year-old with no family history of colon cancer, but you want a screening colonoscopy just because, well, that shouldn't be covered at all, or you should have a tremendously high copay. So I think payers get this part pretty well, right? And they would definitely charge this patient a lot or not cover the procedure at all. It's this part that hasn't picked up, reducing the out-of-pocket burden or the cost sharing on high-value interventions. In my discussions with payers, they say, look, if we do this, then we become the bad guys, because now we are making the decision about who gets what, basically, right? And so I think it's one of the reasons why this hasn't picked up. But to take it a step further and to be even more controversial, moving beyond just vanilla value-based insurance, let's talk about performance-based insurance. Now this is where things get really tricky. And this is what we're seeing a lot of in Europe, but virtually 0 here. And so how this works is that if the drug works, the manufacturer gets paid. If not, the manufacturer has to provide a discount or free drug. So for example, you start treatment, you get a response, treatment keeps going, and the treatment is reimbursed. If you have a non-responder, treatment is stopped, and there's a discount or complete reimbursement of the drug. So in the UK, there are some plans, and in Italy as well, there's some plans like these that are already underway, and one of them is bortezomib. And so for example, if with bortezomib, for multiple myeloma, you don't see a 50% reduction in M protein by cycle 4, your next one's free. Meaning for the next patient who comes along with multiple myeloma in the NICE system, they get drug for free. And there are other examples of this. So Erbitux in Italy, for example, similar plan. We are nowhere near seeing anything like this in wide distribution in the US, but this is where you start getting more bang for your buck. And this is where you start, honestly, holding people's feet to the fire. So health systems. I am from one. We are in one now, and health systems have a responsibility. And the first responsibility comes around transparency. So I think you all remember Stephen Brill's article in Time magazine from a few years ago, where he talked about the charge master. So the charge master is this huge document where every health system lists the price of everything from knee replacement to Tylenol and how much they're going to charge patients for that. Of course, those are all completely confidential. So he looked at some charge masters and he looked at some bills that patients received. And here's one example. So CTs, 3 CTs cost this patient $6,500 is what this patient was billed. However, based on Medicare standards, that patient should only have been billed $825. If you look at how much a CT chest, abdomen, pelvis cost at Duke versus 15 minutes away at UNC, you're going to see variation there. And that's because everything is completely confidential and we have no price transparency. What we know, based on evidence, is that when you have price transparency, prices go down. There was this fascinating study in Health Affairs a couple years ago where they looked at prescriptions of MRI, just outpatient standard MRI. And there are 2 arms geographically. The control arm, people got prescribed an outpatient MRI, they got their MRI, end of story. In the intervention arm, people got prescribed an outpatient MRI. They got called by the payer who said, I see you're going to facility A. You can actually get it at facility B, and it'll be less expensive for us, but not for you. Would you mind doing that? That was the intervention, a phone call, and a request to go to a different MRI facility. So in the control arm, MRI prices started somewhere around $900 in 2010 and increased to around $1,000 a couple years later. In the intervention arm, MRI prices started, somewhere around $1,000. If they followed the control arm trend, you would have expected it to go up to around $1,200. But instead, because of that phone call, prices decreased by $200, and that was a significant amount. Not only did MRI prices increase, but radiology facilities started competing with each other for patients, because that's what price transparency can do. If we saw more of that, we would see prices go down. So those are some policy interventions. Policy interventions are great, and we need them, but they're not going to change care tomorrow. They're not going to impact our patients' pocketbooks tomorrow. That's where we come in. And this is where a lot of my work has focused as well. And I think we have to be a part of this picture. So we did a study where we asked patients whether or not they wanted to talk to their oncologist about their costs of care. And these are all patients on treatment. And about half said they wanted to have that cost discussion. But interestingly, only 19% had actually talked to their doctors about costs. So what we see here is this disconnect between a desire to talk to somebody, actually to talk to their oncologist about cost, and actually having the cost discussion. So then we asked patients, well, why didn't you do it? Why didn't you talk to your doctor about cost? The vast majority said, well, I wasn't having enough problems that I wanted to bring it up. But 28% said they wanted the best care possible, regardless of cost. So in my mind, that sort of links cost to quality, where patients fear that if they're getting care that is less costly to them, it is also of poor quality. So then we asked the 19%, so again, very small exploratory sample of patients who said they talked to their oncologist about cost. And we asked them, after you had a cost discussion, did your out-of-pocket costs decrease? So what proportion of patients said their out-of-pocket costs decrease after having a cost discussion? Give me a percent. 80%? 50%? Oncologists in the room are a little bit more pessimistic. 57%. So 57. You weren't off. So more than half of this very small sample said their out-of-pocket costs were decreased after having the discussion. Not they felt better. Not their quality of life was better. Not they had more trust in their physician. Their costs were lowered. So these were all Duke patients. And when I presented this data at our grand rounds, I said, this is your patients. A lot of people who tell me, at least in private, they don't want to talk to their patients about cost. They're doing it. And they don't realize it. What they're doing is referring patients to financial assistance or advocating on behalf of their patients with the insurance company and actually decreasing costs 75% of the time without changing treatment. As an oncologist, that is critical to me. Because if I find a treatment that is good for my patient, I want that patient to get it. I want to help them afford it. I don't want to give them something that I think might be a lesser treatment. And so my point here is we're doing this already. We're already helping our patients with costs. We need to do it more efficiently and more effectively. So there are tools out there. I don't think they're great, but one of them is ASCO's value framework, which was just released a few months ago. And basically what it does is it takes effectiveness, places it next to toxicity, combines those two together in a net health benefit score, and then in a little box over here, you can put drug acquisition cost and then predict the patient payment, which is impossible to determine. So really what this is a good tool for is weighing effectiveness versus physical toxicity. I don't think it does a whole lot for financial toxicity, but I'm assuming this is going to be developed over time. There are others that are doing it. NCCN has done it. ICER has done it. But this is the one example I think that is very relevant to us. And then finally, there's interventions at the level of the patient. All right? And I think patients do have a responsibility here as key stakeholders. So there was a study that was published in the Proceedings of the National Academy of Science last year. 3,000 people nationwide were asked very simple questions about healthcare, health insurance, like this. What's a deductible? Only 60% answered this question correctly. And I say only 60% because I don't think you have to be a patient to know what a deductible is. And yet, a large proportion of patients go into this new catastrophic diagnosis without having any background in the finances of healthcare. And we can do more to help them with that. We can do more to educate them. We can do more to link them with financial resources, and we can do more to help promote that conversation. And so that's what we are trying to do in that we've developed an app for patients called Finance. Financial Assistance, Navigation, Communication, and Education. I'm very proud of that acronym. Spent a lot more time working on that than I did the actual app. But this is preliminary. We sort of have a very basic sort of beta, actually not even a beta, sort of an alpha out there right now. And it has 3 parts. So the first part is to link patients to relevant financial resources. So if they start on imatinib or they start on regorafenib, they put in their insurance information, their income, and their other demographics, and they see a list of patient assistance programs for which they're eligible. Second is education. So if patients want to learn more about how the Affordable Care Act impacts their accessibility for clinical trials, or what, or what Part D is, or what COBRA is, they can get that tailored education. And the third is pretty cool, I think, and it is a tool to teach patients on how to communicate about costs with their provider if they want to, right? And it's based around the framework for sensitive discussions around end of life. So one of my collaborators, James Tulsky, who is now no longer at Duke, had developed this platform in palliative care. And what we've done is transformed it, gone from end of life discussions to cost discussions. It's video based. I'm just going to show you this very brief 40-second introduction video to show you sort of what it's about. So we've done some usability testing on this using a very common tool to test web-based usability. This was considered more than above average usable by patients. We asked our patients, our pilot sample, about effectiveness as well. 71% said the tool was helpful with their financial concerns, and 94% said it improved their knowledge about financial aspects of cancer care. A second app that we're developing, we've partnered, so for this I'm currently begging the NCI for money to develop it further. Let's see how that goes. A second app that we're developing, we've partnered with a small business that has developed their own app called, their company's called Viver, where they're the part of the app where they sort of link patients to patient assistance programs based on income and insurance. We're submitting an R43 small business grant to fund that beyond pilot. So what you have is various levels of interventions. Policy interventions are very important, but before those are ever enacted and effective, it is our responsibility to help our patients. We're very focused on helping our patients with the physical toxicity of cancer care. What we need to do more of is help them with the financial toxicity of cancer care. Thank you.